So it's kind of hard getting to the root of the problem. Most cases, erectile dysfunction is caused by something physical, like the heart disease, clogged blood vessels, high cholesterol, blood pressure, diabetes, Parkinson's, Peyronie's disease, which is kind of like a curvature in the penis developed from plaque, and it can go in different directions. We are doing injections for Peyronie's currently. It's still under a Reams review program.
Is that Botox?
No, it's actually it's Xyloflex medication, and it's an injection, and the patient can have up to 4 cycles in each plaque. So I have a patient right now that has 3 curvatures, so his thing goes like in multiple directions. So the medication goes into the plaque. They have 3 appointments per cycle. 2 appointments for injections, and then the 3rd one is to break it up. So that med is to help break up and dissolve that plaque. So the 3rd appointment is literally bending it and manipulating it, which I don't do.
So you gotta wonder why.
3 curvatures, 3 injections.
No, you can have up to 4 cycles.
Right, but if
Each cycle is 3 office visits.
If they have 3 curvatures,
So they could have 12.
Yeah, wow.
They could have 12 cycles. Yeah. So a cycle is the 2 injections, and then the molding is what we call it. And then they come back. Does it look better? Does it feel better? And they can do that up to 4 times per spot. So we work on 1 spot at a time, the worst one first. Because some of the guys, you may not see it till they are erect, and then it's painful.
How common is that occurrence?
Now that people are willing to talk about it, a lot.
yeah.
This
They
is
used
the
to
first
call
time I've
that
heard of it.
bent nail syndrome.
We call it wonky willies. And it's kind of sad. Yeah, there's other guys coming in now with it and stuff, and new relationships, new weddings, and it could be from a partial break that was never checked out before, scar tissue, and it's like more or less callous scar tissue in there. So it's kind of cool to be.
Cancer too tight.
It's kind of cool to be a part of this Reams program. The next thing they're going to test Xyloflex on is cellulite, so I'm excited. I was like, I'll be your test patient. Let's see. ED treatments, oral medications. Oral medications are successful. There's the good old Viagra. I have coupons for you guys for any of these too,
Oh boy. Can any of this erectile dysfunction stuff be used for women who have low libido?
No, but there is now finally a cream, alprostadil, which usually is put in like urethral suppositories. They're little pellets. It's also known as mousse. To put into the urethra. And basically for women, it's a cream, and it's kind of to rub on the area. And from what I understand, it engorges the area. It engorges G-spot and all of that. It just brings more blood flow down to the area. That way you feel it more.
Because I'd heard rumors that women were being prescribed Viagra for libido issues.
These medications, they only release more nitric oxide, which helps relax everything, right? It relaxes all the muscles and all of that, so the blood flow can rush. And girls don't work that way.
Yeah.
I wish. No, but they don't. But most medications, that's the nature of it, is to enhance the nitric oxide to allow you to get an erection response. Now, these medications do not just cause you to walk around with a full-on. You still need stimulation. You still have to be stimulated so that your body starts already releasing that, so that what you took works with it. And it's over when it's over. As long as you climax, orgasm, whatever we want to call it these days, then it's over. Now, if it doesn't, that's when you got a problem. There is issues. If your erection does not go down, that blood could start to clot, and then it's not going anywhere. So it's called
That's where you're supposed to
priapism.
have an erection that lasts more
Yeah,
than
that's
4
what
hours.
I was just thinking.
It is true. There's only a few things our doctors go running for.
That's what.
Testicular torsions and priapism.
Really?
Yeah, because they
So-
stick a needle in there and they drain it
So
all out.
the blood is in there, but it's not moving?
No, it becomes stagnant. It's not flowing.
Because it
Oh,
starts
that's
to
weird.
clot, is that why it's not flowing?
And or the effects of this and the relaxation wore off, and it's not going in and back out. It's staying all down there. Yeah, people can have medical conditions they weren't aware of that also could cause that on a normal basis. We seen the guy that doesn't take anything, and he wasn't even having sex, and he came to our clinic with priapism like twice in a week, and then the next week a few more, and it was just him. He wasn't doing anything to induce it. So we had to get a medication. There is medication, I can't remember the name off the top of my head right now, but it's an injection to help dissolve. If that doesn't work, then they do go in, worst case scenario, with a big 8-gauge needle. And
So nothing preventative to help with it, you just have to deal with it when it occurs?
if it occurs. And at 3 years, I've probably had one call from a guy that's actually using this. Otherwise, it was health conditions that was causing it. It wasn't the medication. Yeah. There's injections for erections. A lot of guys use that after like prostate surgeries where they don't have the blood flow all in that area anymore. Trimix, Hoagland's makes a Trimix compound, which is cheaper than using any of these other Cabergex or Edex, but a lot of the ingredients is the alprostatil. Majority of these medications have that in there, which is,
Hoagland's is one of the only compounding pharmacies.
yeah. They make our estrogen compound and stuff too. We get a lot of things compounded if insurances won't cover good stuff. Hoagland's works really good with you.
They do.
They'll make stuff. They're making, for testosterone, they're making us right now, usually there's a pump that's like $700. You just get a pump a day, and they're making a compound for us right now so that we don't have to fight these insurance companies. It's like, he's 19, we took both testicles out. What do you mean I need more proof he needs testosterone?
Yeah.
It doesn't make sense. That's like the worst in, I hate insurance companies. So the muse is at the top there for the urethral suppositories. We don't really prescribe much of that because, again, it's another one to get a hold of, and we are trying to get that made as well as an insertable gel. They're making it in an injection, Hoagland's is, so they're going to work on, they have to work on how they're going to bill it before they'll give us the cocktail, which makes sense because Trimix right now, they don't bill all of the ingredients, so it's cash pay. No insurance will cover it. It's about $90 for 6 milligrams, and they need a 0.3 to 0.3 each time. And it doesn't last, the medication doesn't last long. So, kind of sucks. Yeah, it's super
Is
expensive.
there a certain age group that you see ED in, or is it?
All sorts of ages, yeah. There's people that have testosterone deficiency and hypogonadism, and then they have ED. Some people take ED meds to help with hypogonadism and just to feel better, so they're not sluggish instead of taking the testosterone and all that other stuff. I have a patient who takes Viagra daily. If he's going to have sex or not, he just feels better. He just feels the flow down there better. He's not in pain down there.
So age isn't really a factor.
It can be, most definitely. I've got 90-year-olds that don't need any of this, which it's hard for me at my scope or whatever I do to be able to put a number on an age, but you see them all. Yeah. Usually it's after a prostate surgery because they don't want to lose that function, and half the time they didn't get the surgery in time because they know that's a complication they can have. We have the penis pumps. Medical term is vacuum erectade devices. Until October, I think 2015, you could get those covered on insurances, but then they realized that Medicare and Medicaid put out over, it's like $13,000 one year for ED issues, and that has to do with medications, creams, pumps, surgeries, all sorts of things. So they don't cover it anymore.
Is that it?
Yeah, that's part of it. Yep.
Oh my.
And then there's Vino
Big part of
seals.
that.
You broke it, Jake.
This is a
broke
really
it.
old school model.
Oh my.
Kinda sounds like me.
So this is a ring, a Vino seal. Some men have Vino leaks, so they can get it up there, but it might the blood might just fall right back out. So this basically, I know there's other names for these. I'm sure you guys all know what I'm referring to. They go on, you tighten it, and the little knobby here is to occlude the vein underneath the shaft so that all the blood can stay. Now I think this is a really poor design, but it's one of the only ones insurances will cover.
Of course.
Basically, you can use this together with the pump. You put the pump on,
Uh-huh.
and you and your doctor
ahead,
will
Dave.
determine what pressure you're going to go to.
Where's the camera?
It's right there.
We want still shots. Oh, flattery will get you everywhere.
Do it again.
It should say
So they
baby,
have
baby.
these. Since they're not covered anymore, I don't really pull this out of the cover. Because patients don't want to pay $700 for these. Yeah. So you are connected. Oh, I don't have the connector piece. There you go. So between you and your doctor, he's going to decide how much pressure you're going to do, and of course, you're probably not going to follow his recommendation.
No, of course not.
Of course not.
And you
More is
pump up-
better.
Bigger, better.
It might not on your skin. So let's say you're at the pressure you guys determine is going to create the erection worthwhile for you. Then you can choose to use these rings. So before you take that off, you're going to roll this
Roll
off,
it down.
and that's going to be your Vino seal basically. Or you can use this one because these are super, super tight. You can use a few at a time, different spots throughout the shaft, depending on what your plan with the erection is, I guess. But you always put the rings on after you have an erection. Some people don't get that, but that's what it's for.
Don't they use these rings to take tails off the dogs?
Oh, Dave.
Sure.
They use it to castrate sheep.
I see this, I'm going, oh no.
That's a good one.
This here is a penile prosthesis. So I only have one of the sides here. I don't know. So picture two of these. Yeah, I have fun at urology.
Urology sounds pretty cool.
It's pretty
You need
fun.
help holding something?
I'm afraid.
You should be.
Yeah, you should be.
This is a G-rated presentation.
I asked not to be recorded, but so pretend we have two of these here. So basically, the shaft kind of gets rooted out, basically, and you have one in each side in the corpus of the penis, right there. This is your release. This isn't a testicle, and your ball reservoir is in the abdomen.
Wow.
So when you want an erection, you. I don't even know if these work as those.
Do they use anything similar in gender reassignment?
You have to plug the other hole.
No.
I don't have the whole thing here. So you would push this to pump it up, and then you got an erection. When you're done, you find this in your testicle, you push the button, and down it goes. We do these for sphincters too, artificial sphincters. So if men's sphincters are so open for dysfunctions and or after surgeries, they kind of look like a really, 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 really small donut, and the air stays in the sphincter, keep it closed. When they want to pee, or it's really important if you're going to try to go put a cath in them, they find the release in the testicle and you push it. Usually you have to push it 2 times slowly to keep it open long enough for a whole urine stream, and then that air goes into the stomach while it's out of the sphincter, and then that goes back on its own.
Is that
So
the
this
actual
little-
size of what goes inside the test?
This real,
Wow.
That looks kind of big.
there's
I
different
know.
sizes.
Right, but
I think this one's bigger. maybe. Yeah, this one's bigger. Yeah, so these are kind of cool. Our 2 new doctors are really into doing these types of surgeries.
Okay.
And what kind of surgery would have been performed that would have been required?
Probably a prostatectomy.
Oh, okay. Okay.
Yeah. Probably a radical prostatectomy, the whole thing, not just pieces of it.
Do your doctors use the Da Vinci?
Mhm.
How's that been going for prostatectomy surgeries?
Good. A
Having
lot less
a lot of
patient
less.
waits. A lot less. A lot less phone calls because it's not so common. They get good education on the way out, let alone are they drowsy and probably don't retain if they did.
Right.
But we just talked about that work. We're having less phone calls, less
Nice.
post-op concerns, and
That's great.
How about like surgery success rate, like less post-op issues, like for?
they're doing statistics on that now because I guess we were planned to have that machine paid off with procedures in 2 years and they just did it in 9 months, I think.
Wow.
They've done that many surgeries. So when Casperson actually makes it
Yeah.
here, she's gonna explain that stuff, the bigger stuff that's out of my scope. I just know it because I'm there. Yeah. But if I were to have a surgery that you could use that, I would go for it. I really would.
Interesting.
Yeah, we're gonna go over and watch
Oh,
something.
that would be
hopefully
neat.
soon.
When they had it kind of in the learning lab at the hospital and they were inviting people to come over and play with it.
It's like a video game.
Yeah.
Dr.
really
Rez
cool.
and Dr. Roeder, they are younger doctors. I think they're 34, 35 maybe. They said they're just like playing video games. They're
Yeah.
like, next, and they don't have to scrub in, their assistants do. So
Oh.
Natasha, our PA, will go and scrub in and she'll be the one changing the hands, you know, and he'll be controlling them. That's kind of cool. I don't know it all yet, but I'm gonna go watch one. It will be fun.
Yes, very interesting.
Okay, what else? Oh, this is from our Viagra rep, who is awesome. She's so funny. So this is how they rate an erection, and it's just kind of a visual we do with patients who don't explain themselves very well. So, are you this? Are you this, this, or this? So they kind of just tell us how they're doing,
Nice. At least they're not really penis shaped.
Yeah,
right? Everything on the wall is, though.
yeah. Yeah, that's true.
This is a Cunningham clamp, and this is used sometimes after a prostate surgery. Men may dribble a little bit. They're not in retention. They're not having overflow. They just don't. It's more like stress. They just don't have those muscles tight down there because we took a pretty big piece out of it. So if you think about it, it doesn't show it very well. Yeah, I think one of these, I was going to show the anatomy of how the urethra goes through. Where is the penis? There. So this is the prostate right here. So you got the urethra that comes through it. So when that's enlarged, it's just like strangling the
Yeah.
urethra. So take that all out and look how much loose
Yeah.
space is. You got a pre and post, sphincter here. And that's not used to probably that gush coming
yeah.
through if they were in retention before the procedure. So as they work on their Kegels and stuff, because that's where we refer them to, this clamp goes on their penis to just save themselves the embarrassment or whatever of dribbling. It's curved on the bottom, and that part's used as the occluder. So they just put it on their penis and release it when they need to pee, and that just stops the excessive dribbles. It's called a Cunningham clamp. They have other ones too that aren't as big.
Doesn't look super comfortable. Yeah.
No, it doesn't.
No, but the men that, you know,
Those bag clips would work just fine.
Yeah.
Oh, just put some foam in there.
The potato chip.
Just put some foam in there.
Yeah.
did that, did that, did that. Oh, the condom catheters. What'd you do with them, Dave?
Right there.
Passed them around.
Yeah, that's
Somebody took them.
One thing you have to do when you're ordering a condom cath, it's kind of the same idea as the Cunningham clamp or neurogenic bladders or people that have total dysfunctions going on where one day they are drip, 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 one day they can't pee or what have you, or maybe their bladder's quivering. They just have that constant drip. So these condom catheters come in different sizes, and depending on what style, the style is the sticky part. So it can be sticky at the base, the middle, the top, or all the way through. And that's the style. To get the size, you have to measure the patient's girth, which is kind of, I'm just like, here, tell me what number you are. You obviously don't want them to exaggerate or their condom cap's going to fall off. So you have to let them really understand why you need a good measurement. But basically, you just roll it on, which is easy on a finger, and then you attach it to a catheter bag. Now, if someone had a condom cath, I would give them an extender to where they've got an extender, otherwise it's not pulling. But yeah, this isn't gonna go anywhere. This is gonna stay, and it's gonna fill up the bag or not. There's also bags that look like a balloon. That way they can kind of just tuck it under, and they don't have to worry about it.
How often do they change that?
Daily, or if it falls off. Because the only really thing you got to watch out for with this, because there's not going to be a backflow. I had a patient once that was worried about backflow. I was like, well, then you should never swim. But you get those patients, you just have to be blunt with. Would be the constant moisture on the tip of the penis, yeast infections, things like that. That's the really only thing I stress to them to change it, because you'll get that patient that doesn't want to. But then they come back with an irritated penis, and you're like, how often were you changing it? But these stay. They're not going anywhere.
You're going to fall off then.
I never gonna lie.
That's all.
But then they're easy to take off, and there's no sticky residue.
Oh,
So it's kind of cool.
How do they stick so well then?
I know, it's crazy.
Do I dare?
You know where that's been?
Yes, it's.
Alright, so there's that, that. What else do I gotta show you? Catheters. Yeah, let's do catheters.
Are you looking for volunteers?
Yeah.
These used to have names, but I don't remember what their names are.
Matilda and George.
What were yours? I don't think these will fit.
Oh, yeah, I see.
They're too big.
Wow.
So a fully, I'm putting it in the female just so you can see the balloon action here. These are made to just practice straight catheters on the
Now, did you get certified to do that? Or did you?
I learned everything hands-on at urology.
Okay. Because, we don't learn that at MH
No,
yet.
I went through the MA program here. Yeah. So you put the catheter in, and there's this little balloon, and you typically, the bags on these catheters say like a 5 cc. We never put a 5 cc unless it's super pubic and their bladder has shrunk down from years and years of it just never having to hold it. It just leaks out. But this is kind of how it looks, and that's why it can't come out.
Okay, because,
That's how Steve
And I always feel
Yeah,
sore
you
to
can
rip
rip
those out.
Yeah, that's 10 cc's. We do go up to 30 on some people.
Wow.
Men usually that leak around the tube. A lot of the time it only leaks around the tube if the tube's stuck. That's a 30.
Wow.
It's ready to pop.
Yeah.
If there's a lot of sediment clogging the tube and some patient coughs, it's going to exit the quickest way it can, which would be around the tube. If you got a heavy person and lean over, well, you just kinked your tube inside. So I try to explain this to patients sometimes. You know, they're heavy set. This is probably kinked inside because this can push pull. And that's one way you check to make sure you're in the right spot. In men, that you're past the prostate, is that you can do a push and a pull. If you can't, then you're between the prostate or whatever suprapubic, you're between skin layers. Because the suprapubic and all of your layers, you gotta hold it when you remove a catheter and hurry up and put the new one in, because it's like dropping a stack of punched paper. You gotta figure out the route again, and that is so difficult on a heavy person. So a lot of the times we just tell them make position changes slower, or, you know, just kind of watch the way you're sitting. If they're sitting at home all day and they said leak, 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 well, probably you should lean back a little maybe, and, you know, then it's not kinked, and then it won't leak around, because it can actually make it in the little holes of the catheter that are down in here and out through the tube. This one's super small. We don't use these unless they're on kids or a new old lady that has never had a cath before. The bigger ones we use suprapubically in the stomach, or men that don't want that, and they just, long use of this, they can rip their urethra. So we just have to keep going bigger and bigger with the catheter, and bigger and bigger with the balloon to help seal it up, so they're not leaking.
Have you had men pull out?
Huh?
Have you ever had men pull out?
Oh yeah, so some men, like after a transurethral resection of the prostate, they'll go home with a catheter for a few days, and they're instructed to take it off at home. Now we don't give them syringes because that's too many tools, they get confused. So we just tell them to cut it off above the fork. I tell them get in the shower, cut it off. By the time you're done with your shower, just give it a pull. That way the mess is in the shower, but it takes probably like 3 minutes for it to, excuse me, slowly drip out. And these are water in here. These are cap kits. So if someone comes in and they're just getting a straight cap, which is the one that just goes in and out just to drain the bladder, you got everything you need in there. But if you're doing a change, then in your kits, you've got, you know, you work from the top down. Where everybody at is cool. So you've got your gloves first, and you go with your little sterile drape that you're going to tuck under their tush. So we'll pretend we're dealing with a female, so they're spread in front of you. Then you got your fen drape here. I never use these. It's how are you going to put a catheter through there and then try to take it off through the bag?
Right.
You would have to rip it. I usually don't use these, the fen drapes. And then they come with the syringe of water. So you get an empty one to withdraw, and then you put a new one back in. So it's not air. And then you got your iodine and stuff in here, your lubricant. But the kits come in handy, so you're not running around the clinic looking for all these individual supplies.
I've seen a man, I used to work in intensive care, and I had a man pull it out with the balloon.
Yeah,
I've had
yeah.
that too.
So we have them cut it, and sometimes they're just so overwhelmed